Aprovecho y ya saludo entonces, ya estamos online por, por YouTube. Esperamos un ratito que se haga la hora, pero para los que ya se estén conectando, les esté saltando la alerta que siguen el canal, que sepan que faltan todavía 3 minutos. Buenas noches, ya estamos en vivo por Zoom también. Les vamos a pedir un poquito de paciencia los primeros minutos que estamos conectando eh, la plataforma por la que va a salir la versión traducida en, en tiempo real.
Si querés, ya, si está listo eso, teóricamente, si querés pasar el link para los que quieren entrar ahí,
Es el link que me enviaste al WhatsApp.
al WhatsApp. Igual en inglés es muy claro, la clase no tiene, se comprende perfectamente, por más que la traducción no esté textual, ¿no? En cuanto escuchándola, ¿no?
El Zoom ya está abierto, César, ¿eh?
Bueno,
Aviso por las dudas, que ya está, Juanpa ya lo conectó, así que falta un poquito, les pedimos un poquito de paciencia, vamos para respetar el horario a todos, los que están llegando sobre la hora, esperamos unos minutos, pero estamos próximos. Eh,
Vicente, ¿estás ahí para presentarte al profesor Resnick? Abrí la cámara, Vicente, si puedo. Ah, ¿cómo te va, Vicente?
¿Qué
Eh,
hace? ¿Qué
Let me
hace?
introduce you al doctor Vicente Paus, who participated last night in the IGNIC conference. Si lo querés saludar al profesor Resnick, Vicente.
Mi inglés es muy malo como para
No,
hacer
pero para que lo
preguntas.
traducimos. Nacho, ¿está por ahí?
Es un honor, creo que para todos nosotros, tener la presencia del profesor por toda su larga trayectoria y para mí realmente es un honor poder estar en este evento y poderlo escuchar.
Well, Dr. Vicente is saying that it is an honor to have you here, that you are an eminence in this field of the medicine, and he's very proud and anxious to be here with you.
Thank you.
Hace más de 40 años aprendí la artroneumografía de rodilla a través de sus enseñanzas.
He says that nearly 40 years ago he learned, lean ahí, te pido ayuda en los conceptos
the
médicos.
the arthroneuroneumography technique with you.
I see. Well, it's very nice to see him and thank him for the nice words that he said.
Te agradece Vicente por las palabras y dice que es un
Ok,
honor
ok.
también.
Vicente, ¿cómo estás? Ese es mi hijo Nacho, que lo metimos ahí para que nos ayude. Para algo se le pagó el inglés. Que haga su first certificate.
Perfecto.
¿Sigue estando la traducción en castellano, Gustavo?
Sí, en YouTube sí, no la pudimos desactivar. Es como que cuando salís en
Bueno,
vivo
bueno,
lo tiene
bueno.
activo y lo van a ver. Me parece que ya te lo impone YouTube para la gente
Listo.
que lo ve muteado, le
Bueno,
aparece la alerta
vamos.
y lo pueden seguir.
Bueno, vamos
Ya estamos,
entonces. Estamos en hora.
sí, ya
We
está
are at
abierta la
time.
sesión, ¿eh?
Perfecto. Nacho, si querés traducir la introducción que le mandé. A ver si está Nacho por ahí.
Estoy acá, ¿querés que te lea lo que vos me
No, no, no,
pasaste?
lo digo en castellano para la gente, así se lo vas traduciendo. Bueno, muy buenas noches a todos. Eh, es una noche especial, una noche donde es un gran honor y un gran placer tener al invitado que tenemos esta noche. Si
Good
querés,
evening,
Nacho.
everyone. It's an honor to have you here, and it's an honor to present the doctor we have tonight here with us.
A mi edad de 29, 28 años, al final de los 80, había empezado mi residencia en Diagnóstico por Imágenes, donde solo había radiología y ecografía, elemental ecografía.
At the age of 28 or 29, at the end of the 80s, I began my residency in diagnostic imaging, where we only had radiology and still elementary ultrasound.
Tanto mi instructor como nuestro chairman nos recomendaba la lectura de los tomos de osteoarticular del profesor Resnick.
Both my instructor and the head of our chair recommended us and as an avoidable reading Professor Donald Resnick, osteoarticular volumes.
Como comentamos hace un rato, algunos años después tuve el placer de poder escucharlo en vivo en nuestro Congreso argentino.
Some years later, I had the pleasure in the early 90s of being able to enjoy not only his knowledge, but also his invaluable teaching ability at our Argentine Congress.
Desde entonces, que era la década del 90 hasta ahora, sería imposible describir el enorme volumen de producción científica y educacional del profesor Resnick, que siempre estuvo desde esa época y hasta hoy en el primer puesto como referencia de la patología osteoarticular.
From then until today, it would be impossible for us to describe his enormous scientific and educational production that until today positions him as number one worldwide as a reference for osteoarticular pathology.
Quiero por eso agradecerle su presencia esta tarde porque es la tarde en San Diego, y también agradecerle su predisposición y su calidez para facilitar la organización de este evento tan importante para nuestro medio, para nuestra facultad y para nuestra sociedad. Así que quiero agradecerle porque siempre que me he comunicado se nota su calidad docente ya desde el momento que uno charla con usted.
That is why I want to thank you for your presence this afternoon, as well as your willingness and warmth in facilitating the organization of this event for our Faculty of Medicine of the National University of La Plata.
Thank you very much. Los dejo en compañía entonces del profesor Donald Resnick, profesor emeritus of radiology of la Universidad of California, San Diego, former chief of osteoradiology de la Universidad of California, San Diego, pero sería imposible, como dije recién, describir toda su trayectoria. Así que muchas gracias y lo dejo en compañía del profesor Donald Resnick.
Thank you again, and we leave you with Professor Donald Resnick to listen to him.
Thank you very much for the introduction. It's a privilege to be with you today. I'm lecturing from my home in a small town in Southern California, Del Mar, California, just north of San Diego. It's a privilege for me to be able to speak about subjects that I really enjoy. And for this particular presentation, we will talk about the knee. I will give 2 lectures, each about 45 minutes in length, after which we will see if there are any questions, and hopefully some that I have answers to. The first of the two lectures will deal with the meniscus of the knee. What we will look at will be the function and dysfunction of the human meniscus. I have three general objectives for this particular lecture. To review meniscal structure, emphasizing the collagen framework. Number two, to emphasize classic patterns of failure of the meniscus, understanding why we see what we do on the imaging study. And then finally, we will also talk about some diagnostic pitfalls that may arise as you interpret MR images of the knee meniscus. So we begin by looking at the anatomy of the meniscus from the point of view of the femur, looking south toward the tibia. The medial meniscus is on your left, MM. The lateral meniscus is on your right, LM. And the first thing that is obvious is that the shapes of the two menisci are not the same. The medial meniscus is a more elongated structure. The lateral meniscus is more an oval structure. Indeed, the lateral meniscus covers more of the lateral tibial plateau than does the medial meniscus of the medial tibial plateau. There are several ligaments that connect one meniscus with the other. I show you the most common one here, the intertransverse meniscal ligament. Now, this drawing was made for me about 20 or 25 years ago when I first learned about the root ligaments of the menisci. We'll talk about them later in this lecture, but they are labeled 1, 2, 3, and 4. Two of the root ligaments relate to the medial meniscus, numbers 1 and 2. Two of the root ligaments relate to the lateral meniscus, numbers 3 and 4. Those ligaments are important. They stabilize the menisci in place by anchoring the meniscus to the subjacent tibial surface. When I was a first-year medical student, I learned an important fact that the human meniscus was largely avascular. When you look closely at the blood supply to the human meniscus, there are two sources. The first of these, numbered 1, are branches of the nearby genicular vessels forming a plexus in the outer portion of the meniscus. The second source of blood, labeled number 2, are the synovial reflections at the top and bottom of the periphery of the meniscus. As you look at my drawing, and as you look at the pathology, you can see that there is a peripheral vascular region and a much wider avascular region. Orthopedic surgeons shorten this to the red zone of the meniscus and the white zone of the meniscus. Those meniscal tears that occur in the red zone, the vascular region, have a good prognosis. They might heal on their own, and they certainly will heal through meniscal surgery. But those tears that involve the avascular or white zone of the meniscus, in fact, do not heal and are difficult to treat arthroscopically. So typically, partial meniscectomy with debridement of the tear is accomplished. Now here I'm showing you a drawing of the medial side of the tibia, with 3 triangles representing the meniscus, the medial meniscus, the posterior horn, the body or mid-body, and the anterior horn. If we look at the widths of the 3 portions of the medial meniscus, in general, the posterior horn is the widest. Therefore, as a quick survey of the integrity of the medial meniscus, you can utilize a sagittal MR image. Under normal circumstances, the width of the posterior horn should be greater than the width of the anterior horn of the medial meniscus. If we do the same experiment in the lateral meniscus, the results are different. The widest portion of the lateral meniscus is the meniscal body, and the anterior horn and posterior horn are about the same in terms of meniscal width. So a quick survey of the lateral meniscus shows the posterior horn and the anterior horn to normally be about the same width as shown in these 2 images. Now, this is a complicated slide, and I'm going to go slowly over it because this is one of the critical slides in my lecture. Collagen is key to understanding the way the meniscus fails. Here, taken from the literature, showing you the composition of the collagen within the human meniscus. If we peel away or take away the superficial portions of the meniscus, we find a highly organized tissue in the middle with 2 types of collagen bundles. The first of these we call longitudinal circumferential collagen bundles. I show them by the yellow arrow. They run in the outer half of the meniscus, and they connect the anterior horn and the posterior horn of the meniscus. Here I show you in a transparent meniscus, in red, these are the longitudinal circumferential collagen bundles. The second type of bundles are the radial tie collagen bundles. I show them with the orange arrow and the orange arrowheads. These fibers come in from the periphery and go all the way to the central portion of the meniscus. They tie together the central and peripheral portions of the meniscus. So that's all you have to know. Let me go over it again very quickly. 2 types of collagen bundles. The first, longitudinal circumferential collagen bundles, found generally in the outer half of the meniscus, connecting the anterior and posterior horns. The second, radial tie collagen bundles that connect the central and peripheral portions right here of the meniscus. That is all you need to know about the collagen bundles. Now, there are many different patterns of meniscal tearing, but there are only three basic patterns. We will discuss them. Longitudinal or circumferential vertical tears, which tend to occur in the outer half of the meniscus. Horizontal or longitudinal horizontal or circumferential horizontal tears that begin in the inner aspect of the meniscus and extend out to the periphery. And then finally, radial tears that start centrally and extend out to the periphery and are vertical in pattern. 3 basic types of tear. longitudinal vertical, horizontal, and radial. Now, why does the meniscus fail? In order to show you how it fails, here is a sagittal section through the posterior horn of the medial meniscus. This is the femur. This is the tibia. Here is an axial load applied to the knee. The axis is oblique because of the curvature of the femoral condyle. This particular oblique force can be changed to a horizontal force and a vertical force if we do vector analysis. The vertical force is resisted by a similar vertical force from the tibia, but the horizontal vector is not resisted. So it produces hoop stress that tries to drive the meniscus from the joint in a peripheral direction and also drive the meniscus both anteriorly and posteriorly. Hoop stress and circumferential stress are the reasons that a meniscus fails. Here, you can appreciate hoop stress on the meniscus, resisted by the longitudinal circumferential collagen fibers. Here, we see circumferential stress resisted by the radial tie fibers. So that is how the collagen helps protect the meniscus. Now we come along and we're the imagers, and we have certain rules that we have to diagnose a meniscal tear. There are two classic findings of a meniscal tear. I've listed them here. One is excellent, and the other is terrible. It is very poor. The normal meniscus typically is of low signal intensity. It is smooth. It is triangular with an apex, a pointed apex. One of the criteria is an abnormality of meniscal contour. The meniscus is truncated or it is irregular, okay, as shown here. The second criterion is an abnormality of meniscal signal, where intermediate or high signal violates a meniscal surface. The meniscal surface may be the top, it may be the bottom, it may be the apex, but it is not the peripheral portion of the meniscus. So those are the two criteria that a radiologist uses to diagnose a meniscal tear. The excellent criterion is the abnormality of meniscal contour. As long as you can eliminate prior meniscal surgery. Now, perhaps you depend upon the history, which is good, but sometimes you don't know if there's prior surgery. So the first thing you need to do is to look for evidence of surgery. That evidence is typically seen anteriorly, and with a right-handed surgeon, it dominates anteromedially. It may take the form of scarring within the anterior interval of the knee. It may take the form of thickening of the ligamentum mucosum, or even rarely, it may take the form of a cyclops lesion, a nodular area of arthrofibrosis. So your job, number one, is to look for evidence of surgery. And if you don't find it, this is a terrific criterion for diagnosing a meniscal tear. The second criterion, an abnormality of meniscal signal, is overrated. and in my view, a poor criterion. It originated owing to the development of a grading system related to the degree of intermediate signal intensity within the meniscus. Grade 1 was minor signal, grade 2 was a little bit more signal, and grade 3 meant violation of the meniscal surface. Grade 3 was said to represent a meniscal tear, whereas grade 1 and grade 2 were not a tear, but represented meniscal degeneration. So this looks like a good criterion, right? But it isn't. The difference between no tear, excuse me, and a tear is whether you think that violates the meniscal surface. So what you're talking about is 1 pixel of information. You're going to look very closely to decide if it's a tear. Well, I noticed years ago when we trained our fellows and residents that when they looked at the signal, they got closer and closer to the monitor like this. They even pressed their nose against the screen, trying to make that last pixel bright so they could make it a meniscal tear. Indeed, they would even do windowing like that to try to prove that the meniscal signal violated the tear. Grade 3 signal should be evident at a distance. Sit back. You should see that signal at a distance. And generally, you see it in more than 1 image, often in more than 1 plane. This led to something called the 2-slice touch rule, where you could see signal violating the surface of the meniscus in more than 1 image. And you can see, based on this data here, that using the 2-slice touch rather than 1-slice touch, that the predictive value for both the medial and lateral meniscus was pretty good. So my rule, sit back, look for violation of the meniscal surface, and it should be evident in more than 1 image. It should be evident in at least 2 images. Okay, let us now look at the 3 basic types of tear. The first is the longitudinal vertical tear. There is an axial load placed on the meniscus. Hoop stress tries to drive the meniscus from the joint. The initial tear is a microscopic tear in the direction of the hoop stress. Look at my drawing. Here comes the microscopic tear, and it doesn't go far because it encounters a longitudinal circumferential collagen bundle. So it changes direction. It takes the path of least resistance, becoming a vertical tear in the peripheral portion of the meniscus. Longitudinal vertical tears often occur in young persons following an injury and are seen in the outer half of the meniscus, all right? That is critical to understanding them. So here I go to my transparent meniscus, longitudinal circumferential fibers, and radial tie fibers. And here comes the tear, a longitudinal vertical tear. The longer this tear, the more radial tie fibers that are violated. And what do? They connect the middle and peripheral aspect of the meniscus. So if you have a long vertical tear, the inner portion of the meniscus may displace centrally, and what do you have? You have a bucket handle tear of the meniscus. A displaced longitudinal vertical tear is a bucket handle tear of the meniscus. So here's the tear, all right, on my drawing, right there, right? Vertical in the outer half of the meniscus. The length is its anteroposterior or circumferential dimension. And we come along and we image it. And here's what it looks like. This is a complete one running from the top to bottom in the outer half of the meniscus. Let's stay in the same plane. Let's take another image right here. And what does it look like? It looks exactly the same. It is vertical and is at the same distance to the periphery of the meniscus because it is paralleling the longitudinal circumferential collagen fibers. Frankly, it's boring. Every image looks the same. Here's the first image. Here's the second image. Here's the third image. Here's the fourth image. Every image looks the same, all right? A longitudinal vertical tear of the meniscus. Those longitudinal vertical tears that involve the posterior horn of the lateral meniscus are particularly significant to the orthopedic surgeon because in most of us, there is no red zone in the posterior horn of the lateral meniscus. And because of that, the treatment of these tears in the lateral meniscus is more complicated. The second basic type of tear is a horizontal tear or longitudinal horizontal tear, also known as a cleavage tear. This tear occurs in older people, often associated with meniscal degeneration. And this tear begins not in the periphery, but in the central portion of the meniscus. So it begins near the apex, and it takes the path of least resistance, extending out to the periphery. Often in the periphery, it branches because of all of these collagen bundles. So this is a cleavage tear, a free edge horizontal tear extending to the periphery. Here it is, a horizontal tear. And when these become large, they open up like a fish mouth, a wide appearance centrally. The length of a longitudinal horizontal tear is its circumferential dimension. The width is its central peripheral dimension. Now, you know these tears because these are the tears that are often associated with parameniscal cysts. Typically, the cysts are bright, representing fluid derived from the joint, extending through the meniscus and collecting within the parameniscal cysts. With regard to parameniscal cysts, they are more frequent on the medial side. They are larger on the medial side. They are more frequently associated with meniscal tears on the medial side, and they may occasionally produce bone erosion. Here's a classic example of a large medial parameniscal cyst. Whenever you see it, go back and find the tear. Sometimes those cysts develop and extend centrally behind the posterior cruciate ligament, simulating paracruciate ganglion cysts. So parameniscal cysts. The final tear is a radial tear. And this, my friends, is the most difficult one to diagnose with MR imaging. This tear also begins in the inner margin, but it does not have an antero-posterior dimension. So look at it, look at my drawing. Here comes the radial tear. It extends centrally out toward the periphery, disrupting those longitudinal circumferential collagen bundles. This is what it would look like in the sagittal plane. Note how sharp the edges of the torn meniscus. That's classic radial tear. The longer the radial tear, the longer the distance it extends to the periphery, the more of these longitudinal circumferential fibers are destroyed. And what do? They tie together the anterior and posterior aspects. So radial tears open up like a book here, sharp. This is not a piece of meniscus that's missing. This is a radial tear that has opened up like a book. Now we come along and we image it. And radial tears disrupt the normal bow tie appearance of the meniscus like this. Here's what they look like, radial tears. Here's what they look like on the MR examination. When we image a radial tear, sometimes we see nothing, a space, because the radial tear has opened up. Here is fluid. Here is the anterior horn of the medial meniscus. This is a large radial tear that has opened up like a book. A parrot beak tear is a displaced radial tear, shaped like the beak of a parrot as shown here. Let's image that, and what do we see? We see a vertical line in the inner half of the meniscus. This is not a longitudinal vertical tear. This is a radial tear, all right, in the inner portion. Let's stay in the same plane. And that vertical line marches. This is known as the marching cleft sign. So the general rule is listed here. Vertical lines in the inner aspect of the meniscus usually indicate radial tears, not longitudinal vertical tears. I see that mistake made over and over again. That's a radial tear. Let's look at this example. Here is a parrot beak tear. Here's my drawing. Let's image it, A, B, and C. Here's a vertical space that is marching toward the periphery of the meniscus, known as the marching cleft sign. Now here is another critical slide, very important slide. In the normal situation, in the sagittal plane, if you find the posterior cruciate ligament on that image or the next medial image, you should see a lot of meniscus. And on the next one, the entire meniscus. This is normal. This is abnormal. Here's the posterior cruciate ligament, and here there's virtually nothing. So there is something wrong. We should be seeing meniscus on that image. So it should not surprise you that when you look in the coronal plane, you see an abnormal space right here, representing in this case a radial tear. Normally, the posterior horn becomes the posterior root ligament of the medial meniscus. In my view, the most important single place for you to look for meniscal tear is the coronal image through the posterior horn of the medial meniscus. In fact, this is the most important 1/2 image in the entire MR examination for meniscal tear. You want to study this region very, very carefully. It could be a radial tear, or as I'll show you in a few minutes, a tear of the posterior root ligament of the medial meniscus. There are two types of free edge tear, the horizontal tear and the radial tear. The horizontal tear is ill-defined, fuzzy. The radial tear is very, very sharp. There are three classic patterns of displaced meniscal tear. A displaced longitudinal vertical tear is a bucket handle tear. A displaced horizontal tear is a flap tear. And a displaced radial tear is a parrot beak tear. Here's what they look like. This is a bucket handle tear. Here's the peripheral portion, and here is the central portion of the meniscus. Here is a flap tear where a portion of the meniscus has displaced inferiorly and is eroding the tibia. And here is the parrot beak tear with the marching cleft that we spoke about earlier. So let's look briefly at the bucket handle tear, typically related to a longitudinal vertical tear in the periphery of the meniscus. This is the handle, even though the handle typically is not very wide. All right, you can see that here. This is the bucket out in the periphery. There are three criteria for diagnosing a bucket handle tear. Number one, there should be a peripheral rim of meniscal tissue. Number two, there should be a central displaced meniscal flap. And number three, these should be connected both anteriorly and posteriorly. So look at this example in the coronal plane. Here is the anterior horn, and here is the beginning of the bucket handle tear. We follow it posteriorly. Here's the peripheral portion and the central portion. We see it here, we see it here, and then posteriorly it reconnects and becomes one piece. Often with bucket handle tears, there is paracruciate meniscal tissue. With a bucket handle tear of the medial meniscus, we see the double posterior cruciate ligament sign. Here's the meniscus, here's the posterior cruciate ligament. With a bucket handle tear of the lateral meniscus, we see a pseudo tear of the anterior cruciate ligament. Here's the anterior cruciate ligament in the back. This is the central portion of the torn meniscus. Now, there's one other thing I want to concentrate on for a bucket handle tear, and that is something called condylar entrapment. Here's the bucket handle tear. What occurs sometimes is the central piece inverts, and becomes located upside down, inverted within the central portion of the meniscus. It then can be caught inside of the ipsilateral femoral condyle, known as condylar entrapment. Here is what that looks like. Here is the bucket handle tear with the entrapped portion entrapped adjacent to the medial femoral condyle. When that occurs, okay, often there is kinking at the junction of the peripheral and central portion, producing something that is known as the V sign of a bucket handle tear. These are two cases. Look at the V, very characteristic of a bucket handle tear with a central inverted portion. Occasionally, we deal with something designated a hemi-bucket handle tear, a horizontal tear where an inner portion is displaced. Here's what it looks like. All right, you can see that nicely here. And here's another case, a horizontal tear with a central displaced meniscal flap. And then rarely we have a flipped meniscus, where the failure is at the meniscocapsular junction and the meniscus is displaced and inverted as shown in this example. We're going to finish up by here is the anterior root ligament right here of the medial meniscus. Here is the anterior root ligament of the lateral meniscus, which is intimate with the footprint of the anterior cruciate ligament. And here is the posterior root ligament of the lateral meniscus, extending over, attaching to the intercondylar eminence of the tibia. The one that I will talk about is the posterior root ligament of the medial meniscus. Here's what it looks like right here. All right, intimate with the attachment of the posterior cruciate ligament. So look at this example. The most important 1/2 image of the MR examination. There should be meniscus here. There is not. This is either a radial tear or a root ligament avulsion. Because of that, it is not surprising that the body of the meniscus is peripherally extruded because the root ligament is torn. There is bowing of the medial collateral ligament, and there is edema both deep and superficial to that ligament. Often there is also marrow edema. One of the interesting findings in recent years has been the association of root ligament tears with something that we used to call spontaneous osteonecrosis of the knee, or SONC. These are really insufficiency fractures that develop when the root ligament is torn. The cushion is displaced and abnormal stress produces these stress fractures involving the femoral condyle. When I was a resident, I learned that it was a normal variant to see a small area of ossification within the posterior horn of the medial meniscus. We now know that if you see that ossicle within the posterior horn of the meniscus, it may represent an avulsion of the posterior root ligament. And then finally, in this first lecture, a word or two about the popliteal meniscal ligaments. If you look at the posterior horn of the lateral meniscus, there are several ligaments that connect it to the joint capsule. This is the antero-inferior ligament. Here, slightly more medially, is the postero-superior ligament. So here, postero-superior, antero-inferior, and then sometimes there is a postero-inferior popliteal meniscal ligament as well. This is the attachment of the posterior horn of the lateral meniscus to the joint capsule. Abnormalities of these ligaments may be developmental or they may be traumatic. This is what a tear looks like. And if there is a tear of the popliteal meniscal ligament, there's abnormal mobility of the posterior horn of the lateral meniscus, which in this case is displaced superiorly. So look at this example. This was a young patient who came in with lateral knee pain. He purported that earlier his knee was locked. Note that there is tearing of all of the popliteal meniscal ligaments. 1 month earlier, in the same patient, the knee was locked, and that's because intermittently what occurred was the posterior horn was displaced adjacent to the anterior horn, producing a locked knee. So what I've done in my first of 2 lectures, we've looked at meniscal structure, we've emphasized collagen, we've looked at the 3 basic ways that the meniscal fails, and I've shown you some of the problems that we have with the accuracy of MR imaging. I want to go directly on to the second talk. Again, we're going to concentrate on the knee, and we are going to look at bone and cartilage injury, anatomy, and pathology, with one general objective: to emphasize the pathogenesis and proper terminology of a variety of injuries that include chondral delamination or cartilage delamination, cartilage fracture, osteochondral fracture, subchondral fracture, and bone contusion. Let us study this particular subject. During an injury, there are 2 types of forces that may be applied. They both may occur together, or one may occur without the other. The first is the external or environmental force. This is an automobile striking the leg, or perhaps the helmet on a player from the opposing team. When we deal with external force, most typically, the end of the bone is not involved. Therefore, here is the external force applied to the shaft of the femur with the bone contusion and soft tissue edema. But usually the end of the bone, the cartilage, and the subchondral bone are not involved. The second force is the internal force, 2 bones colliding. Typically in the knee, it's the femur and tibia that collide, but it might be the patella striking the femur during a patellar dislocation. It is internal force, the force of 2 bones colliding, that typically produces cartilage injury and injury to the subchondral bone. So if you see something at the end of a bone, it is more often internal force than external force. So internal force is the main cause of chondral and osteochondral injuries. And there are a number of injuries that we may see. At the lesser end, bone contusions or bone bruises. In the more severe end, osteochondral fractures. How do you, the radiologist, tell the difference between a bone contusion and an osteochondral fracture? You do so by knowing what the normal contour is to the end of the bone. This is a lateral femoral condyle, sagittal image. Normally, as I'll talk about later, you don't see this. This is a depressed piece of bone. This is a fracture. This is a bone contusion. They look very different, as we will note. Now, compression and shear forces, the effects are dependent on the surface that they strike. They're not the same in rubber, in glass, and in cement. And the most complicated reaction occurs when compression and shear strikes water. And the reason that is important, as we're going to talk about articular cartilage. Articular cartilage is an extremely well-hydrated structure. 65 to 80% of the wet weight of cartilage is water. So that affects the changes that occur with compression and shear. Among the dry components, collagen is key because it's the collagen that transmits the force from the surface of cartilage into the deep layers of cartilage. So let's look at the structure of articular cartilage. Here's the histology, and here is my drawing of what it looks like. This is non-calcified cartilage. I'm showing you it in blue. It consists of various zones and rows of cells. Deeper down, we have something that is called the tide mark. It is a histologic landmark visible to the pathologist. Below that, we have a layer of calcified cartilage, which is this area right here. Below that, we have a layer of compact bone. More about that in a moment. And below that, we have the subchondral bone. So that's the architecture of the end of a bone: cartilage, compact bone, and subchondral bone. Now let's go ahead and put the collagen fibers in our drawing. At the surface, there are parallel layers of collagen, known as the lamina splendens. Below that, there are arcades of collagen, known as the arcades of Benioff, that extend from the superficial to deep portion of cartilage, anchoring the cartilage into the subchondral bone. Now, a word about this layer of compact bone. I want to be sure your terminology is correct. In the human body, there are two types of compact bone. The first of these is cortex, like this. That is compact bone formed by the periosteal membrane. A second pattern of compact bone is at the end of the bone. Here, it's formed by the articular cartilage. This is not a cortex. If you are calling that in Spanish a cortex, you are wrong. That is a subchondral bone plate, or whatever the Spanish equivalent is for that particular term. I've heard many experts get up at major meetings at the podium and say that is a cortex, which it is not. That is a subchondral bone plate. Compact bone, but not a cortex. Here, taken from the literature, electron microscopy showing you the collagen, the lamina splendens at the top, and the arcades of Benninghoff that extend down into the deeper layers of articular cartilage. So what happens when compression and shear forces are placed on the articular cartilage? Well, the first thing that may occur is cartilage fibrillation. In the English language, fibrillation means a process forming fine fibers or fibrils. I don't know what the Spanish equivalent is, but this is what cartilage fibrillation looks like. The second term is fissuring. In the English language, a fissure is a split or crack that is long and narrow. This is what chondral or cartilage fissuring looks like. Vertical clefts within the articular cartilage. And my favorite one is right here in the central aspect of the trochlea, often producing a black line, as shown on this MR image. That is fissuring. Chondromalacia is a term that is misused by many people. Malacia, in a medical dictionary, means abnormal softening of tissue. Laryngomalacia, osteomalacia, and chondromalacia. It is a particular pathologic process usually seen in the patella in young persons, shown on MR as abnormal signal intensity. That is chondromalacia, not chondral fissuring, not chondral fibrillation, and not chondral loss. It is softening of cartilage producing abnormal signal. And then the word delamination, or its Spanish equivalent. In the English dictionary, delamination is a mode of failure in which a material fractures or separates in the layers. That's the definition. So chondral delamination would mean the cartilage is separating in the layers. Now we see delamination in cement. We see it in ceramic. We can see it in wood as shown here. The situation in cartilage is a little bit more complex. When we talk about delamination of a tendon or of a ligament, we talk about failure that is parallel to the collagen bundles, not violating those bundles. That's the definition of tendon or ligament delamination. But in cartilage, we have collagen rows and collagen arcades or columns. And we have cellular rows. So there are different patterns of delamination. Whether you're using cells as your point of reference or collagen as your point of reference. So in this diagram, I am showing you pictures of what is described in our literature as cartilage delamination. The first of these, labeled number 1, is delamination of cellular rows, producing these defects in the mid-zone of articular cartilage. 2A is showing you delamination of the surface collagen, those we talked about, those rows of collagen at the surface in the lamina splendens. That produces fibrillation of articular cartilage. 2B is horizontal failure at the tide mark, separating the non-calcified and calcified cartilage. And finally, 2C is vertical delamination parallel to the columns of collagen. Now, I'm a collagen fan. I believe in collagen. So I do not call this delamination because that's related to rows of cells. Rather, these patterns, 2A, 2B, and 2C, are true delamination of articular cartilage. So here's what delamination of cellular rows would look like. These horizontal patterns of failure separating rows of cells within the articular cartilage. This is what delamination of surface collagen would look like. Here with electron microscopy, here with histology. This is fibrillation of cartilage. Delamination, it looks a lot like the way roof shingles fail, right? This is delamination at the surface that should be called fibrillation. And now we have vertical delamination parallel to the arcades of Benninghoff. This would represent fissuring of cartilage, and then horizontal failure at the tide mark. Here's what it looks like. There is the here, and there's the delamination at the tide mark of the articular cartilage. Now the arthroscopist comes along, and he or she can easily pick this up because the surface is disrupted. But the arthroscopist will have problems in a case like this, where the delamination is deep and there is no surface vertical failure. This is more difficult to pick up. It is concealed at the time of arthroscopy. Now, to finish our story of delamination, in very unusual circumstances, when there is weakening of the subchondral bone, there may be delamination of both cartilage and weakened subchondral bone. And there are two situations in which you will see this. The first is osteonecrosis, where fractures in the necrotic bone, the so-called crescent sign, can extend up and lead to delamination of the subchondral bone plate and the articular cartilage, as shown here. The second situation is primary or secondary hyperparathyroidism. You know it best as subperiosteal resorption of bone. But hyperparathyroidism also produces subchondral resorption of bone, weakening of the subchondral bone. So with minor trauma, cartilage and portions of the subchondral bone plate may be delaminated, as shown in this example. Now, to finish our story of articular cartilage, a few other words. Flap. In the English language, it means something that is attached loosely at one end only. So this is a cartilage or chondral flap. In the English language, defect means something that is absent, lacking, or deficient. So this is a chondral or cartilage defect. In the English language, the word fragment means something broken off and completely free. So here is a cartilage fragment within the posterior recess of the ankle joint. And rarely, fragments invert and become located upside down. This is most commonly seen with injuries involving the lateral aspect of the talar dome, producing a defect with an osteochondral fragment that is inverted 180 degrees, an inverted fragment of bone and cartilage. Okay, in the second part of this lecture, we're going to talk now about the subchondral bone. In order to understand it, you need to know about Wolff's Law. Again, I don't know what the Spanish equivalent is of this, but here is Julius Wolff. He was a German anatomist and surgeon, and in a series of articles, he described a law that could be applied to the development of bone. Here is what the definition is. Bone in a healthy person or animal will adapt to loads under which it is placed. Now, for those of you who have read some of our articles from University of California in San Diego, you would recognize that most of our analysis is by sectioning cadavers, imaging and sectioning cadavers to understand anatomy and pathology. Every time I section a cadaver, I see Wolff's Law at work. Let me show you. Here is a sagittal section through the tibia. Here is the collagen within the anterior cruciate ligament. And look at the orientation of the trabeculae parallel to that collagen. That is Wolff's Law at work. Or how about this section? This is a sagittal section through the patella. Here is the collagen within the quadriceps tendon. And look at the orientation of the trabeculae, similar to the collagen. That is Wolff's Law at work. Or how about this specimen? This is a section of the proximal tibia. Here, the trabeculae oriented along the axial load applied to the articular cartilage. That is Wolff's Law at work, resisting the force applied to the surface of articular cartilage. So let's look now at what happens when we apply a force to the surface of articular cartilage. It is carried through the cartilage, reaching the subchondral bone plate, and then exposing the force to the subchondral bone. That force in the subchondral bone is resisted in two ways. First, by the vertical and horizontal trabeculae, shown here, and second, by hydrostatic pressure of the material that is present in each of these chambers. And as you should know, typically in the adult, this is fatty tissue, fatty marrow. So the hydrostatic pressure of the fatty marrow also resists the force applied to the surface of articular cartilage. It's like a automobile tire. What occurs is compression of the automobile tire, which pressurizes the air within the tire, producing tensile force on the walls of the tire. And as long as you have a good tire, you don't get a flat tire. The same thing is occurring here within the trabecular chambers in the subchondral bone. If the tensile force placed upon the walls of the chamber is greater than the strength of the trabeculae, we begin to see failure in the bone. The least severe pattern of failure in the English language is called a bone contusion or bruise. This is what it looks like. It produces a speckled pattern of altered marrow signal, looking like the stars that you see at night, said to represent hemorrhage and edema within the chambers and about the trabeculae within the subchondral bone. Here's what it looks like diagrammatically. Here's what it looks like in a specimen. That is a bone contusion or bone bruise. Now, when we will go ahead and interpret the MR examination. We use two words, a chondral injury or an osteochondral injury. So what's the difference between those two words? With a chondral injury, all of the force is dissipated or disappears within the articular cartilage. With an osteochondral injury, some of that force is dissipated in cartilage, but it also reaches the subchondral bone. So I'd ask you, the people listening to this lecture, do you think we're better at picking up chondral injuries or osteochondral injuries? And the answer should be obvious. We're better at picking up osteochondral injuries because we look at our fluid sensitive sequences and we look for a light bulb. The light bulb is the reaction of the bone to an injury that went through the articular cartilage. That is an osteochondral injury. When we deal with chondral injuries, we may see nothing. Here is a sagittal image of the front of the knee, patella, and trochlea. Initial study, I don't see anything following the injury. 9 months later, delamination occurring at the tide mark of the articular cartilage. No light bulb. These are the injuries that we miss. So because of that, I would recommend to all of you listening, when the orthopedic surgeon comes in alone or with a group and asks you, looking at this image, what will the articular cartilage look like later on? A lot of times we cannot predict. This is an osteochondral injury with a light bulb, right? The force came through the cartilage. It looks pretty good here, but 11 months later, there is a chondral defect. So be very careful trying to predict what's going to happen to the articular cartilage weeks, months, or years later. A chondral fracture or cartilage fracture is defined as a fracture isolated to articular cartilage that does not extend through the subchondral bone. So let me tell you how I would interpret this case, how I would report it in English, and perhaps you can translate how you would report it in Spanish. This is an osteochondral injury. There's a light bulb that has led to a chondral or cartilage fracture that has produced a cartilage defect that measures so much. We would measure it with an intact subchondral bone plate and a subjacent bone contusion. That is how I would describe this injury. Or how about this one? In English, this is a chondral injury. There's no light bulb. Producing a chondral fracture, leading to a chondral defect with an intact subchondral bone plate and no bone contusion. And I would call your attention to something very important. When you're dealing with traumatic defects, often the edges of the defect are very, very sharp. When you deal with degenerative chondral defects, often there are sloping margins at the edge, as shown here. An osteochondral fracture is defined as a fracture that extends through the articular cartilage, here are two examples, violates the subchondral bone plate, and extends into the subchondral bone. Here are some classic ones. These are the fractures, the osteochondral fractures that you often see when there is a tear of the anterior cruciate ligament. Okay? That is what we see, particularly when the orthopedic surgeon says there's a positive pivot shift test. I don't know what the Spanish is for that. But if there's an anterior cruciate ligament tear with a positive pivot shift test, often you will see abnormalities involving the lateral femoral condyle. Normally, there is a small notch in the mid portion of the lateral femoral condyle. If it measures greater than 2 millimeters in depth, it is abnormal. That is an osteochondral fracture. If it is this long, it is abnormal. That is an osteochondral fracture. And if you see 2 notches, it is abnormal. This is an osteochondral fracture, all characteristic of complete tears of the anterior cruciate. And staying in the lateral compartment, even the tibia, the posterior aspect of the lateral tibial plateau, that's not normal. That's depression of the subchondral bone plate. That is an osteochondral fracture. All of these generally indicative of tears of the anterior cruciate ligament. So if we summarize the difference between an osteochondral fracture and a chondral fracture, these typically occur in younger people. These occur in adults. These fractures often have fat and blood within the joint effusion. Chondral fractures are generally not bloody. These fractures are visible radiographically because the bone is involved. These fractures are generally invisible. And most important, osteochondral fractures have a good healing potential. Chondral fractures have a poor healing potential. The next lesion is a subchondral fracture. This is defined as a fracture that extends through the subchondral bone in a linear or curvilinear fashion, shown here. The subchondral bone plate is normal, and the overlying articular cartilage generally looks normal. This is an osteochondral injury. There's a light bulb leading to a subchondral fracture line. The main differential diagnosis is an osteochondral fracture. This is a subchondral fracture, linear or curvilinear. This is an osteochondral fracture. So what do you do with a case like this, where we see a line and maybe a little bit of change at the periphery? In cases like this, sometimes I'm not sure, is this an osteochondral fracture or is it a subchondral fracture? And also stress fractures. Subchondral stress fractures are seen particularly in older persons, producing lines like this here in the subchondral bone of the femur and tibia. Finally, in the last 5 minutes or so, let me prove to you that fat is your friend. The identification of extruded marrow fat can provide very important information regarding the presence and pattern of bone injury. Let me show you what I mean. The first example is obvious. The presence of a lipohemarthrosis. And again, I don't know the Spanish for that word, meaning fat and blood within the joint. The presence of a lipohemarthrosis is very strong, although not certain evidence that a fracture has occurred. When you study a lipohemarthrosis with MR imaging, two patterns are seen. The first of these, the fluid levels, shown here as 3 layers and 2 levels. The superficial layer is fat, the same signal intensity as marrow fat on a fat-suppressed image. The middle layer is the serum of blood. It's bright. And the lower layer has intermediate signal. It's the cellular component of the blood. So this is what a lipohemarthrosis looks like on MR. The second pattern occurs hyperacutely with bubbles of fat rather than layers of fat. And those bubbles are often displaced to the surface of the hemarthrosis shown in this example. The second example to prove fat is your friend is seen particularly in children. If you look at fractures that involve the distal radius in children, they often relate to buckling of the dorsal aspect of the radius. What occurs in those cases is the periosteum is lifted but not disrupted, and marrow fat may be extruded from the bone, collecting within or deep to the periosteum. Here's an example. You see those regions of fat. Here you can see them here. That is extruded fat caught beneath the elevated periosteal membrane. Now I have a reason for showing you that. Because if you look at that patient, later on, you're going to see something very peculiar. It looks like this. It looks like small lytic lesions in the bone. But this is the fat that was released at the time of the injury that has now been located in the thickened cortex that has developed since the injury as the periosteum laid down bone. The third example of fat is your friend is seen in the hand and wrist and ankle and foot. Fractures here of the radius may displace fat that becomes located within a tendon sheath. And here's a beautiful example of tenosynovial fat, indicating there is a fracture in the adjacent bone. And then the final example is my favorite. Let's go back to the bone contusion. We were taught it represents hemorrhage and edema. But I can tell you, if you are a good radiologist and you look at this, you're also going to see fat globules. Look at this example. These are fat globules within the bone contusion, surrounded by a rim of increased signal, likely reflecting fat necrosis. Let me show you another example. Look at this one. That is a bone contusion with fat globules representing necrosis with an inflammatory reaction around it. Look at this one. Multiple fat globules with an inflammatory reaction. These are common in bone contusions. My favorite here, a contusion of the fourth metacarpal, negative on radiograph, negative on CT, but on MR, a marrow edema, and look at all the fat here, bright on T1, dark signal on fat suppression. And these fat globules representing lysis also occur with fractures. Here's an example with CT of a comminuted fracture involving the proximal tibia. And here we can see the little globules of fat in the adjacent bone. So lysis of fat. So let me summarize what can occur, particularly with massive bone injury. There is an injury. There's hemorrhage and edema within the fatty marrow. This leads to necrosis and death of fat cells. These fat cells are released and migrate away from the area of the contusion. Then what occurs is an inflammatory reaction owing to necrosis of those fat cells. You see that on MR imaging. And if the trauma is massive, the degree of fat necrosis can be extensive. And those globules of fat may reach the vessels and may lead to distant fat emboli in other organ systems here in the retinal vessels. So fat is your friend. Look for it with bone contusions. Look for it with fractures. It comes in various forms. So what I've done in my second lecture, we've emphasized the pathogenesis and the English terminology for a variety of lesions that involve cartilage and bone. Cartilage delamination, cartilage fracture, osteochondral fractures, subchondral fractures, and bone contusions. And I put my email address here because I can tell you I have a reputation for answering emails very, very quickly. So if you have a question and we can't address it today, we'll try. You can always email me at dresnick@ucsd.edu, and I will try to answer your question. So with that, I will pause. I'll stop sharing my screen, and I will see if we have any questions. Hopefully, someone will translate them for me if they are presented in Spanish.
We look forward to your question or contribution to the class. And, es decir, esperamos las preguntas o contribuciones a la clase, dudas que el doctor Leandro Massa va a traducir. Si quieren hacer directamente la pregunta en el chat, que es mucho más sencillo.
César, a mí me gustaría
Sí.
hacer una pregunta como cirujano,
Bien.
voy a ir despacio, está en relación a la sutura de las lesiones en rampa en el corno posterior del menisco interno o a la sutura meniscal en la zona roja, si querés ir traduciendo. Yo lo que quisiera
Professor,
saber es cuál es el mejor corte para ver si esa sutura cicatrizó y a cuánto tiempo de la sutura sugiere hacer los primeros controles en imágenes.
okay. Professor, Dr. Paus is asking about the ramp lesions in the posterior horn of the menisci and also in the red suture, which is for you the best plane to assess if that suture is correct and is already healed, and which is the time that we should expect to look forward for a healed meniscus.
Right. So just so everybody understands, a ramp lesion is a characteristic lesion that occurs in association with tears of the anterior cruciate ligament. Originally, it was described as something you saw following chronic ligament tears, but now we use the same term for either acute or chronic tears of the anterior cruciate ligament. It is a tear that is generally longitudinal and vertical at the meniscocapsular junction of the posterior horn of the medial meniscus. And it is very similar to a meniscocapsular separation. So differentiating a meniscal tear in the periphery of the posterior horn from failure a millimeter away in the meniscocapsular junction can be difficult. So both are generally categorized as ramp lesions. Now, acutely, they produce areas of high signal in the periphery of the meniscus. And a very important finding, in a large portion of cases, there is edema in the subjacent medial tibial plateau. Okay, that's very important. Most ramp lesions have edema in the tibial plateau just beneath them. If they heal, and they may heal on their own, they produce a zone, a thickened zone of intermediate signal intensity with strands of low signal intensity extending through them. But that can be a very difficult diagnosis to make.
Ok, traduzco lo que dijo. Él se refiere a que las lesiones de tipo rampa originalmente fueron descritas vinculadas a una lesión del LSA crónica. Luego, obviamente, hizo toda la parte de historia de las lesiones de rampa y lo que se refirió a lo último fue que pueden sanar espontáneamente sin cirugía, pero es un diagnóstico difícil. Generalmente se ve un tejido de señal intermedia entre la cápsula y el menisco. And what about, Professor, what about when the surgeon repairs that ramp tear?
Yeah,
That was the question. Do you have a sequence to assess the the right evolution of that suture?
yeah. We generally, the best sequence will be your sagittal sequence, okay, more than the coronal sequence because it's in the posterior horn. The axial sequence would be your second best. And we would not use any different technique. We would be employing T1 weighted or PD images and a fat suppressed T2 weighted image. So we wouldn't do anything different in that particular situation.
Ok, dice que el mejor plano para la valoración de la sutura o del éxito o la falla en el caso de que se sospeche sigue siendo el plano sagital y luego el plano axial, proponiendo esos dos planos como las mejores para visualizar este tipo de lesiones. usando las secuencias que usamos normalmente para la rodilla. You won't do an arthro MRI for suspicion of failure in that case?
Yeah. So I'm very proud to talk a little bit about that because when MR came along, okay, originally, I was not impressed. And I made the stupid suggestion it would never be good for musculoskeletal problems. And then two of our scholars who were MR fellows showed me in cadavers MR arthrography. So we wrote the first article on MR arthrography, and I thought it was terrific. Nowadays, we have 3 Tesla magnets, and I think the need for MR arthrography is very low. So we use it mainly for hips, looking for the labrum, and occasionally glenohumeral joint, looking for labrum, but rarely do we use it in the knee.
Perfecto. Yo le pregunté si en el caso de que la sospecha persistiera, no hacían una artrorresonancia, y él nos explicó que ellos fueron los primeros en desarrollar las técnicas de artrorresonancia y que hoy en día ellos cuentan con magnetos 3 Tesla y ya casi no tienen indicación de artrorresonancia en rodilla. Lo están usando principalmente para los diagnósticos de los rebordes labrales, ya sea en la articulación glenohumeral o en la articulación coxofemoral. Thank you, professor. ¿Está bien, Vicente? ¿Querés que le pregunte algo más?
Sí, me gustaría saber qué opinión tiene de los injertos de banco de menisco y cómo saber si el injerto está incorporado, porque cada vez estamos viendo más injertos meniscales de banco y tenemos dificultades para poder determinar si ese injerto está incorporado o no.
Okay. So the Dr. Paus is also asking about the meniscal banks transplants, or and is there a way for us radiologists to assess the adequate evolution of that surgery?
Right. So I must admit that our orthopedic surgeons are doing very little meniscal transplantation. And as you know, the technique differs depending upon whether it is a medial meniscus transplant or a lateral meniscus transplant because of where the root ligaments are. On the lateral side, often there is a bone block that is taken that is also used to transplant the meniscus. In the few cases that we have, and I don't have a lot of experience, we have used MR arthrography to evaluate them. But perhaps, you are having a lot more experience with that than we are. Our orthopedic surgeons are not doing that.
Ok, él nos responde que ellos no están haciendo muchos trasplantes o injertos de menisco, que depende mucho también, según su corta experiencia, si es un menisco medial o lateral. En la experiencia de ellos, en el lateral usan un fragmento óseo con la raíz para hacer el trasplante y que en ese caso sí han usado la artrorresonancia para evaluar la fijación del injerto, que en ese caso estarían evaluando seguramente la filtración o no de material de contraste a través de la zona del injerto, pero que no tienen tanta experiencia en eso, y que quizás seamos nosotros o el doctor, por supuesto, quien tenga más experiencia que él. Thank you, doctor. I have a question also. I had some diagnostic challenges when we talk about the posterior horn of the lateral meniscus, basically with the popliteal meniscal attachment. I remember about 3 or 4 cases with knee blocking clinic, and the patient was a soccer player that was a goalkeeper, and they had this kind of knee blocking when they go to the ground to catch the ball, and they spontaneously unblock the knee. And we have an experience about the same 3 cases of 3 different patients with the same lesion. It was a popliteal meniscal disruption in the lateral meniscus, but we couldn't see it in the first MRI because there was no fluid and there was no locking or knee or meniscal displacement. Do you go further down the line, or with the 3T that you are using, you always get those little tears of the popliteal attachment?
Yeah,
We did an arthro CT and an arthro MRI to diagnose the first one.
right. Well, first of all, again, we rarely do arthro CTs now, so that's not an exam that we do often. We use most of our magnets are 3 Tesla, and because of that, we generally do see the popliteal meniscal ligaments quite well. And as you know, many of us have 3 of them. Some of us only have 2. But the case I showed in my lecture is a classic case very similar to what I think you're describing,
Yeah,
in that it was a patient who had intermittent locking of the knee. But then by maneuvering the knee, it
that's right.
stopped being locked. Yet, when we did the MR, we could see in that case, at least, there was enough fluid that showed us that all of
Yeah,
the popliteal meniscal ligaments were torn. Then we got, remember, the old exam that showed the meniscus was flipped at the time that the knee was locked. So it's a classic case. I mean, what you're describing is really a classic. And I think if you have intermittent locking as the clinical history, you want to look very closely at
that's
those
right.
popliteal meniscal ligaments.
Bien, yo le pregunté al doctor Resnick si había tenido algunos casos de lesiones del ligamento del anclaje popliteo meniscal del lado externo, que en nuestra experiencia hemos tenido varios que fueron diagnósticamente complejos porque no tenían líquido y no lográbamos ver bien la disrupción de los ligamentos popliteos meniscales. Y el doctor nuevamente dijo lo mismo, que con los magnetos de 3 Tesla la realidad es que se ven muy bien los ligamentos popliteo meniscales, no van generalmente a un estudio de mayor complejidad como un artro-TC o una artro-resonancia y van directamente al diagnóstico. Y hizo hincapié en algo muy interesante que es el cuadro clínico que le resultó también similar al que le describí, que es el bloqueo intermitente de rodilla en un deportista joven. Así que bueno, fue muy interesante lo que me dijo. ¿Alguna otra pregunta para el doctor? Let's see if we have any other question.
No sé si hay alguna otra pregunta, Gustavo, en YouTube. No, yo no lo veo de acá.
Estoy viendo YouTube, pero no
No.
hay consultas.
Bien. Once again, thank you for your participation, and we hope to have you in the future, and or visit in your university.
I appreciate very much the invitation, and I've enjoyed the participation. So please call upon me again at some time.
Yes. I hope that.
Okay.
Bueno, see you soon. I hope that. No sé si querés algo más, Leandro, despedirte. Porque yo le dije, sí, inclusive.
For me, it was a great pleasure, a great honor to have you here and to talk with you. Also, Vicente Paus, the doctor that is here, the orthopedic surgeon, thinks the same. I know he thinks the same because yesterday in his lecture, he spoke greatly about you. So for me, I insist, it's an honor, and for all of us, it was a privilege. Thank you very much.
Thank you all very much, and I appreciate it too. And you've been so hospitable. I appreciate it. So I'm going to say goodbye now. Okay.
Goodbye.
Bye-bye.
Thank you.
Thank you.
Bueno, excelente. Gracias, Leandro. Excelente la traducción. Y Vicente lo mismo, muy enriquecedora del diálogo. La predisposición y que lo divierte que meterse en estas discusiones y en este intercambio de experiencia, ¿no? Se notó su calidad docente y su capacidad, ¿no? La verdad que gracias por la participación de Leandro y de Vicente.
Gracias, Vicente.
Gracias, Vicente, porque excelente la participación. Hoy le decía,
Sí.
bueno, ahora sí vamos a tener, porque por el nivel del disertante y por el nivel también del cirujano que tenemos, pudieron hacer este intercambio que resultó muy enriquecedor para todos, ¿no?
El agradecido soy yo. Muchísimas
No,
gracias.
no. Muchísimas gracias. Y bueno, nos vemos el 10 de junio. Y muchísimas gracias a todos. Gracias a Nacho Aude, que colaboró hoy temprano con nosotros. Ahí está por ahí. Y gracias a todos por su participación. Muchísimas gracias.
Espectacular la charla.
No, la clase, y hasta claro, eso me pasó cuando lo vi la primera vez, que yo todavía menos leía en inglés. Ahora leo un montón de inglés, hablo menos, pero leo mucho. Y ese día se entendía perfectamente, aún casi no, recién empezaba la residencia. Se entendía lo que este docente nos daba en inglés, ¿no? Increíble la manera de expresarse que tiene, la modulación de la voz, tiene todo como para ser un número uno como es, ¿no? Y no sé la edad, no le quise preguntar, pero si no está en los 80 le pegan el palo, ¿no? Impresionante, la verdad.
Tremendo.
80, es del 44. Tiene
Muy
80.
bien, 80 años tiene. Impresionante, es una buena experiencia para todas las generaciones que vienen. Bueno, nos vemos el 10 de junio. Gracias, Gustavo.
Nos vemos. La
Gracias,
clase queda
Leandro.
grabada para los que lo quieran repasar. Va a
Y
quedar
por favor, configurar la traducción en YouTube. Cuando
una vez
editas
grabada
el
la van
video
a
de
poder
YouTube.
ver con la traducción.
Perfecto. Bueno, gracias, Lea. Muchas gracias por tu participación.
Gracias. Un
Gracias.
placer.